Again, my name is Rebecca Kiesling, and I am the Director of Programs at the Benjamin Rush Institute. Thank you for joining us in our continuing virtual event series. We are thankful for your support as we moved all of our events online due to the coronavirus pandemic. With the uncertainty of higher education in the next school year, we hope to be offering our events again live on campuses. But we definitely will be continuing to offer this series. So please be on the lookout for our lineup. We have some great events coming up, and we'll be continuing these into the fall. BRI, the Benjamin Rush Institute, was started 10 years ago to further the education, the free market healthcare education of medical students across the country and now throughout the world. This medical schools are not giving free market healthcare alternatives to medical students. So that's what Benjamin Rush Institute does, partnering with wonderful free market institutes like the Mercatus Center to offer this education. And we are so very excited to welcome Dr. Darcy Bryan today. Easily said, maternal and newborn health in rural America really lacks obstetrical care, which is at crisis levels now. I was first introduced to Dr. Bryan's work back in 2014 with a book called Economics of Medicaid. I was doing my own work, my own looking at Medicaid and learning more about it, and that's where I was first introduced to her work, which is a book that she helped co-author. Most recently, one of the papers that she worked on, which I'm sure she'll mention, was through the Mercatus Center at George Mason University, called Promoting Maternal Health in Rural and Underserved Areas, which was very recent in mid-April. This is vitally important work because there is just such a need of more obstetrical care, but it's also why this is being underserved, why this continues to be underserved, and even what does rural mean in policy. Dr. Darcy Bryan is a senior affiliated scholar at the Mercatus Center. She's an obstetrician gynecologist with a practice in Women's Care, Florida, in Tampa, Florida. She earned her MD at Yale University School of Medicine and a master's in public administration from the University of Texas in Arlington. Her research encompasses public policy and the impact of technology on healthcare provision. She co-authored the book Women Warriors, A History of Courage in the Battle Against Cancer. I am thrilled to be able to present Dr. Bryan. We have a great group here today. We have some medical students who are specializing in obstetrics. We have current physicians, and we have a number of supporters who have been here with us throughout our series. So I welcome you all today. I am going to turn this over to Dr. Bryan now. And again, please ask your questions because we are going to be, Dr. Bryan's going to speak, and then we're going to turn it over to her to answer questions as well.
I'm very pleased to be here to have the opportunity to talk about something that's very near and dear to my heart. I'm a actively practicing obstetrician gynecologist, and with what happened with the COVID pandemic, a lot of my practices actually shifted over into working as a hospitalist, and Florida is definitely considered one of the hot spots. So I'm seeing quite a few women with active infections with COVID and battling both the virus and working to support their pregnancy. So it's been a challenging time for us all. I initially had my practice in Riverside, California, which, if anyone's familiar with the California area, is the inland regions near the desert. Definitely a physician shortage there. So when talking about the challenges of access for women and taking care of their pregnancies, I do feel particularly strongly about these issues because I've seen in my own practice how women can suffer from access issues. So that being said, I did have the opportunity to write a policy paper and through Mercatus, my work with Mercatus, talking about these issues and how can we actively problem solve the challenges of rural health, but particularly my focus was in obstetrical care. And that has to do with a lot of issues with access, but the issues facing rural America are complex and longstanding. And the solutions, I think, are particularly open to free market and innovative approaches. I'm a firm believer that if you pull a community into solving its own problems, you'll get a greater success. And that's where the free market and innovation comes in play in a very meaningful way. So if you can think about the rural areas of America and what the struggles are, statistically speaking, and statistics can be kind of cold in terms of numbers, but they do make a good point. People who live in the rural areas as compared to urban areas do have higher morbidity and mortality rates, greater rates of poverty, and are typically underinsured or uninsured compared to those who are living in urban centers. So, and then there's huge issues with access to be able to access a healthcare provider, not only just because of sheer distance. Quite often, someone who's living in a rural area can be an hour or more away from a hospital, but also in terms of the amount of providers that are available. There's true challenges in getting healthcare providers, and that encompasses nurses as well as physicians. There's true difficulties in getting providers to stay and work in that area, mainly because the patient population is not as affluent, and so it's hard to get basically paid well for your work, and then you're professionally isolated. So you're under, as a provider, a great deal of pressure and strain, and asked to do things outside your training or your comfort level just simply because other providers are unavailable to support you. And as we're all aware, 21st century medicine is definitely a team sport. And so the more we know, the more complex the healthcare we provide, and the more the anticipation is for good quality and outcomes, as it should be. But if you're a provider and working in an isolated setting, the anticipation is that your patient should do well. But if, let's say, you're working in a rural hospital and that's understaffed and underfunded, and you may not be seeing a high volume of obstetrical patients in your family practitioner, let's say, you're going to be outside at times your comfort level in providing what would amount to high-risk obstetrical care in some of these patients. So what we're basically seeing is a lack of subspecialty backup and providers asked to function outside their training at times. So for example, you'll see in some rural hospitals general surgeons doing cesarean sections, whereas that's really definitely the purview of an obstetrician gynecologist, and outside of that particular isolated setting, it never happens that a general surgeon would do a cesarean section. So that's the kind of thing that as a rural provider you're running into. It's a high stress situation. And the other thing is rural hospitals are financially challenged, and they are folding. About 1 in 3 rural hospitals under a great deal of financial stress, and the National Rural Hospital Association projects that in the next 10 years, 25% of our rural hospitals will go under and be out of business. So you can already see that this presents a huge challenge for women in these rural communities. And what does that challenge look like as a patient in terms of outcomes? We have good clinical evidence, good epidemiological evidence that women who are pregnant in rural America don't do as well as their women who are in cities who have better access to healthcare providers. So if you don't have a reliable access to an obstetrician and also a hospital in which to deliver in, it puts a great deal of stress on you in an already stressful situation. So that pretty much means, in terms of outcomes, that these women are delivering sooner, and so higher rate of preterm labors. We're also seeing more low birth weight infants, which means higher needs, child or neonate at the time of delivery. And we're seeing poorer outcomes in terms of pregnancy-induced hypertension and also postpartum hemorrhage, which are considered preventable causes maternal death and morbidity. But in these settings, we have a greater and poorer outcomes for these women. We're also seeing a greater level of deliveries at home. Now, it's one thing if you're planning a home delivery, which I could really go off topic on all the reasons why that is not always a good idea. But that aside, if that's not part of your plan and you're delivering at home because you simply can't make it at a hospital, that's also a huge risk that a woman is forced to take on. So for all these reasons and these challenges, it's really come forward that women in rural America are truly suffering, that there's an obstetrical crisis at play, that these hospitals and these labor and delivery units are folding. Hospitals for financial reasons, labor and delivery units, also for staffing reasons. It's hard to get experienced providers to staff a unit. So when you see these poor outcomes, basically what happens is, policymakers kind of put their heads together and say, well, how can we turn the ship around? What can we do to try to fix things? And typically, the policy approaches tend to focus heavily on education, tying programs to standing academic centers, training more providers in a rural setting, and kind of a tried and true program models for providing care. And also we try to tweak our Medicaid, Medicare reimbursement and try to create a good funding structure. But all of these things, although they're well-intentioned and good-hearted, don't really get to the actual core of the complex problems that are facing both healthcare providers and women in these rural settings. And so what I wanted to do is present some possible creative and innovative solutions to some of these problems, and also support pulling the community into solving these problems themselves. So that was really the impetus of this paper, and I strongly believe in free market and innovative approaches to problem solving, as well as kind of pulling back the lens and looking at some of the true policy barriers that also can aggravate a problem. So that's kind of the underlying focus of this presentation, is pretty much telling you what the problem is and hopefully some potential ways that we can problem solve. So what can additionally exacerbate some of these issues in healthcare provision in rural settings are policies that are made at the state level. And so some of the policies I'll be presenting will be certificate of need laws, how that can impact provision of healthcare. as well as medical licensure issues and scope of practice laws, and then talking about telemedicine. I think I'm going to pull in this presentation the innovation approach as well, kind of to start the conversation off, and say that the great thing about technologic innovation is that it can leapfrog some of these structural barriers. So we see very similar issues in underdeveloped nations that occur also in rural America. So, for example, issues with reliable roads, issues with medical access to clinics and hospitals, as well as underlying poverty issues, and then issues with internet access. So how well connected, what's the connectivity of the particular area that you're living in? So for example, we've seen innovative approaches in places like Africa or India, which use mobile health, also use, for example, unmanned aerial systems, so drone transportation of blood products to overcome structural deficiencies. And so that's the exciting thing about technology and innovation, is it can help you leapfrog over some truly knotty and difficult to unwind barriers. And so for example, we've gotten a lot of emphasis on telemedicine lately with COVID, which is, if there's a silver lining to a pandemic, which, I don't think there is much of one, but if there is, it's been this big press to change. It's broken the log jam of some of these technologies and approaches that we've had for decades, but haven't been able to utilize because of state policy issues. So, for example, telemedicine is something that's been really brought to the fore because we're all social distancing, right? And so if you can access your healthcare provider through a telemedical platform, that's going to make a big difference in keeping the healthy, keeping the providers healthy, and less exposure to possibly infected patients who are not so acute they need to be in the hospital. And so there's this big push to open up the access to telemedicine, and mostly through CMS's 1135 waivers, basically saying, hey, we'll fund if you provide access, and we'll set aside our regulations temporarily. And I know that there is a push to make those emergency waivers permanent, because we're seeing such good outcomes from telemedicine. So then you ask yourself, well, telemedicine seems like a natural fit in a rural setting. So if you're an hour or so away from a clinic or a provider, you still need obstetrical care, you still need health care. The way to overcome the barrier of distance in a rural setting naturally seems to be through a telemedical visit. And we've got a lot of excellent clinical evidence that shows that obstetrical care can be provided well in a low-risk setting, especially remotely. So the Mayo Clinic OB Nest model is something that I mentioned in my paper, which basically showed that women in low-risk pregnancies with their prenatal care, if you take half their visits and make them virtual, if they have an automatic blood pressure cuff, if they have a handheld fetal Doppler, they're able to give you some of that clinical information during the virtual visit. Then the outcomes at the end of the pregnancy are just as good as a woman who has to go in for a face-to-face fetal well-being assessment. So we're really seeing that this model can and does work well. There's some specialties that are much more of a natural fit. For example, psychiatry and internal medicine. I am a proceduralist, I'm a surgeon, so there's only so much that can be done remotely. You can't deliver a baby remotely, but you can certainly do a lot of prenatal care remotely. And if you think of these women as being under pressure economically to take time to drive an hour or so to a clinic to be seen, take time off work, does put a huge economic pressure and strain. So there's that natural fit of telemedicine overcoming the barriers of distance. However, you also have to look at the financial connectivity issues as well. Financial in the sense of, will a rural clinic have the ability to build a technological platform such as telemedicine requires? Will they be able to have the IT folks, the funding for them, as well as the security? How can you secure the patient's information adequately, as well as connectivity issues? You know, how well cabled or connected is a rural community? I know I've driven through parts of Colorado and lost access on my phone, so and that's in the rural areas and mountainous areas. So there's also some barriers to making telemedicine a reality in these communities from that perspective. But it's still a very positive approach. I believe it has a lot of potential. The other thing to think about is what have been the state barriers to making telemedicine a reality, and that would encompass the complexity of each state's laws. And so, for example, one state may require that a physician have a face-to-face meeting with a patient before they can have future visits via telemedicine. Or another state may require a telepresenter, so that right now I'm talking to you from my home, but it would be the equivalent of saying, well, I had to go to my hospital, sit in the physician's lounge and be able to present to you. So, and have someone nearby to support my presentation. So that is a kind of a level of a barrier, having a telepresenter, having a telemedicine visit in clinic. The other thing has to do with state licensure. So as a physician who may want to practice telemedicine, I have to get licensed in each state that I want to provide my expertise in, which can be administratively difficult to apply for a state license, as well as expensive. So those are kind of some of the barriers. And the other barrier would be compensation at parity. So for example, if you're in internal medicine and having a telemedical visit, you're thinking just as hard about your patient as if you were sitting in the clinic across from them. But that visit may not be compensated equally as a face-to-face visit, which, by the way, I find myself on both sides of the argument on the parity question, parity being in terms of the cost of compensation for a telemedical visit, because I also see that the costs of healthcare are going up, and we want to make it affordable and available to more people than it is right now. So I find myself also arguing the other side, which is, well, maybe it should be less expensive so more people have access. So those are some of the long-standing state barriers to making this technology a reality. But I do think if COVID had anything to offer, which once again, not much in a pandemic, it has pushed the envelope on getting this technology forward and changing how we provide healthcare. I also think it's inevitable that we as healthcare providers are going to have to change how we do business, how we provide healthcare, and be much more conscious of our patients' lives and their need for flexibility as well. Simply because younger and younger generations are used to a personalized approach, things being networked around their unique personality, their need for flexibility. And so it's going to be harder to ask younger folks, quite frankly, to drop everything and sit in a waiting room and to have a 5-minute conversation after waiting an hour to, to see the provider. So they're going to say, hey, wait a second, why isn't this more curried to my lifestyle and what I want? So I do think there's definitely a push towards innovation and providing healthcare in a different and unique way. And also we're seeing our surgical techniques with minimally invasive surgery leading to less use of hospitals and more use of freestanding ambulatory centers. So there's going to be the inevitable shift and press to change how we provide healthcare. So I also did work in and have researched unmanned aircraft. It wasn't part of my paper, but basically drones and how you can use drones to provide healthcare. And we see them used quite frequently in places like Africa to overcome structural barriers and getting blood to remote hospitals. So for example, if you're in a rural setting and have a large postpartum hemorrhage, pardon me, you can easily go through several units of blood and wipe out your blood bank or blood supply in that hospital. And then the next ability to get blood in a timely fashion would require a couple hours of driving. And by then you've lost your patient. So you could even project, as they're already doing in countries in Africa, about transporting blood supply via drone and not relying on infrastructural problems like unreliable roads or things like that. So not that was part of my paper, but it's definitely an innovative approach to providing healthcare. And there are distinct and real regulatory barriers to making that happen in the United States. So that's talking about innovative approaches. I also will mention one more thing, which is, which I also hadn't developed in my paper, mentioned in my paper, which is the freestanding birth center as a way of creating a stopgap from a loss of rural hospitals and labor and delivery units. Most babies are born in the hospital. That's been true for 100 years. But basically, if you're asking a woman to drive 2 hours in active labor and try to make it to a hospital or deliver at home, she's probably going to end up delivering at home. So we could try to think about issues like how can we network freestanding birth centers in these rural communities, make it so that they are supported with surrounding hospitals as possible, so that if you have a woman who's got a very high risk delivery, that you can transport her out. But instead of this kind of all or nothing where you have either hospital or home delivery, that might be a good stopgap to consider too. But in terms of how state barriers, policy decision-making can make these barriers more difficult in rural America, I'll talk a little bit about issues such as certificate of need and medical licensure and scope of practice. I'll pull that in. I kind of went deep into the innovative approaches, but it's important to realize that that state policies quite often get made with really good intentions and then have unexpected and bad outcomes, basically. And there's not a lot of outcome studies or research in terms of policy. We try to make good policy, but once you've come up with a policy, once it's been voted in and it's executed, to go back and circle around and do the studies of outcomes like we do all the time in medicine, like we come up with a new drug or a surgery and then we go back and say, well, was this really such a good idea? Are patients better for it? That almost never happens in terms of public policy. So you're basically stuck with what seemed like a good idea on paper and then has all these unforeseen and essentially bad outcomes. So things like certificate of need laws were developed by states to try to keep the costs of medicine and healthcare down. But what we see and so what is the certificate of need law? It basically says the state health department has to approve whether or not a new ambulatory center gets built or a hospital buys an MRI or any new healthcare provision has to be run through the state healthcare and department. And they basically say, well, we have enough MRIs in our state. If you purchase another one, you're going to be driving up the cost of medicine. Or we have enough ambulatory centers, so you don't get to build one. Or we have enough neonatal intensive care units. Thank you very much. So we put a cap on the amount that of NICUs or neonatal units that are in our state. But what we're seeing is that certificate of need laws actually do just the opposite. They do drive up the cost of healthcare, and they lead to issues with access. So Mercatus has put out some really good work on that. Matt Mitchell in particular has done a lot of work on that. So
just sorry to interrupt you. We actually have Matt Mitchell on the 10th is going to be joining us here on BRI. So great lead in there. Thank you.
Yeah, that would be worth listening. He's wonderful. He's a very, very bright guy. So what we've seen is that states who have certificate of need laws, the impact on their rural community has been to have less hospitals, less ambulatory centers. And so if you were doing an outcome study of your policy and you circled around and you researched, well, gee, what was the outcome of what looked good on paper, you'd actually overturn your law. But like I said, that almost never happens. The other thing is medical licensure issues. So, for example, most of you in your training will go on and be board certified. Board certification is basically your specialty at the national level saying, hey, you know what you're doing, and we're going to continue to watch you and give you articles and test you to make certain that you're staying up to date. And some, and that has its own levels of controversy as well. But if you're board certified, you're certified at the national level. So I find myself asking myself as a healthcare provider, why is it when I'm practicing the same medicine that I'm practiced in California, did I have to crawl through broken glass to get a license in Florida where I'm now practicing? And that whole process is immensely painful administratively. I mean, everyone asks you exactly the same question, but you have to fill out their own unique application with its own unique costs and time and money. And so it creates a real barrier to creating a fluid and mobile physician workforce in this country. And then you look at trying to, let's say you're an expert in New York in maternal fetal medicine. Your particular niche is unique and needed in Wyoming, let's say. And you'd have to, it would be very difficult for you to bring that expertise to the table to a patient in Wyoming via telemedicine. You'd have to, apply for a license in that state to practice medicine, to intervene on the patient's behalf. So there are definitely initiatives to try to overcome some of these licensing issues where compacts are being made amongst states to basically try to streamline the administrative issues. So you have to only apply for one kind of set license, and that information then gets dispersed across the compact states, I think. So that's a move to try to make things administratively easier for physicians. But that's one big barrier in creating a fluid and mobile, temporary or part-time physician workforce. So let's say you do have a spike in COVID-19 in Texas, right? And you want to get providers there who specialize in internal medicine, intensivists, infectious disease specialists. You've got this hot spot, but you have this regulatory barrier. And we're seeing with COVID that those barriers are rapidly pulled away. Well, then you have to ask yourself, well, why are they there in the first place if we're nationally boarded and we all know pretty much the same thing? So that's one issue. The other issue is scope of practice. I work with certified nurse midwives. I can testify that they are a delight and a pleasure to work with. I'm continually grateful that that they're part of the team that I'm on as a practicing obstetrician. So we have nurse practitioners who are very skilled, and then the question becomes, do they need to work under the license of a physician, or can they stand alone on their own license and within their own scope be autonomous? And those are real issues at the state level that is unique from state to state, the ability to function autonomously as a nurse practitioner or a nurse midwife outside a physician's direct supervision. So that also creates barriers in terms of access as well. So I think I've talked about certificate of need and scope of practice restrictions, and medical licensing barriers, and also brought in the telemedicine barriers. So those are some real state level barriers that make accessing a healthcare provider in rural America, as well as other parts of a state, but rural America is already hurting, make it much more difficult to problem solve. And so pretty much the take-home message of my paper was, hey, let's look at some of these policy barriers that are making things worse for people in this community. Let's see about overturning some of that. Yeah, it's great to come up with an education grant and trying to get a rural residency program going. But we've been doing that for years now and haven't really turned the ship around. If anything, things are getting worse. So maybe we should get creative on not only on a policy advocacy level, but also on an innovation technology level, and try to move things forward for the people who are really suffering in this community, women in particular. So that's basically my talk, my presentation, and I look forward to interacting with all of you and any questions you might have.
You actually, you answered some of the questions that we have in the last few minutes. So first of all, thank you very much for that. I have put links to the paper that you referenced throughout our where we're streaming. So if you do want those, if you would like to take a look at Dr. Bryan's paper that she was referencing, please take a look. A question that just came in: why do the states have different? This is a loaded question. Why do states have different license requirements? I would like that it would be unnecessary. I would think that it would be unnecessary to keep others out.
I always feel like I'm being led to the answer.
I did. I actually just read that.
Well, I will quote my scholars who are economists at Mercatus, and I will take how they would answer that question. That way it can appear neutral. There has been the assertion that physicians can be a bit of a guild. So we can be a bit territorial, and competition is, I think, a wonderful thing, but sometimes it can be hard to take. So I think that's probably one component. Is we get a little territorial. We kind of stake our claim to a region, and then we say, well, we would like to really investigate you before you get to join our party. So I think that's probably historically standing a fair answer. You could also say that in terms of state rights, you know, we definitely a republic, and so so federalism is all about layered rights, right? And so to give the state autonomy as who they allow to practice in their region is longstanding state right, and so I think that's probably also the issue. But I don't think it serves states well.
Is there any movement towards a national licensure to make it easier for docs to move across states?
I think from what I've seen, there absolutely is. You know, I think that that argument has been made, but I don't think it's ever gotten past the realm of argument. Yeah.
Yeah. What have you seen? And forgive me if you reference this, but you spoke about rural hospitals, and that they're always in danger of closing. You know, it's always a financial risk. Where are they now because of COVID? How has it impacted them? Do you know?
Well, I did kind of look at this question recently, and what I've seen is in terms of ventilators, they're kind of under the gun because it's even something that here in Tampa we're at maxed out. So if you have maybe one ventilator or two ventilators to your rural hospital, and then you've got really a couple of people who are super sick and need respiratory support, I think that's a huge challenge, is an infrastructure challenge. Yeah.
You spoke about telemedicine when it comes to obstetrics. How can that, and it's a kind of a part by part text that I received. How can that be rolled out in the obstetrics world, or I guess throughout the rural communities, when it comes to the barriers that we're facing when it comes to lack of infrastructure, lack of those provisions? What can we do how can that be rolled out further? Like how do you push that out? I know they're having problems with that with direct primary care as well.
So there's two levels to that question. One is how can it be applied safely and reasonably in a clinical setting? And the second level to that question is how can we support its initiation, and both financially and through infrastructure. So one level to that question is, so to answer the clinical component, telemedicine is really great when you don't have an acute situation like labor. So if that is the case, then you've got issues of maternal fetal medicine specialists being able to interpret ultrasounds, or being able to interpret fetal heart tracings, right, for you. So pulling them in remotely is a huge asset. Or, for instance, even in my own community, I was taking care of a patient who was in the intensive care unit at 30 weeks on a vent. The maternal fetal medicine specialist interacted with the intensivist via telemedicine. So that pulls in subspecialists into the conversation, and that amplifies your sense of security as a generalist, in providing and supporting care for these patients. So that's one component. And then if you're a low-risk patient, we tend to be, as providers, super conservative as what we think patients can do for themselves, right? We think, well, if they don't have me in their life, they're not going to be able to figure anything else out, and they need to see me face to face, right, to help with that. Well, why can't women take their own blood pressure Why can't they find their own, baby's heartbeat? And you help them with, some of those things as to what to look out for, and then pull me in on it if your baby or you fall outside the parameters of normal. So trusting your patient enough to be engaged in their own care. And of course, there's educational issues here and personality issues here. So you have to make your judgment as a provider. Is this person really safe and capable of managing things themselves, or do they need more hands-on in a straightforward clinical in the same room sort of setting? So that's one issue. The other issue has to do with financial and infrastructural support. So these rural hospitals are already financially fragile. To set up a telemedical platform is a cost, right? You have to get the software, you have to get the hardware, you have to get the technical know-how, the people. Like if my computer goes out right now, my only solution is hit the on-off button. That's my technical know-how of my computer, right? But I know that there's an IT person who could do something magical with my keyboard that would fix everything. Well, you have to hire that kind of person to support your system. And you also have to show that you're keeping your patient's information secure so it's not hacked, right? Because there's a lot of privacy issues with healthcare information. So having that kind of hardware, software support for building a platform, and you're asking a rural hospital to invest in it, right? Are they going to? Are they going to have the money to invest in it? And then connectivity, right? We're seeing kind of a definite disjunction between what urban centers have to offer in terms of connectivity and what rural communities have to offer in terms of where does cable get placed? Are these companies laying cable down in your community? And how fast is it really, to support this new technology? So there's that component as well. So it's a difficult problem, but I think it holds a lot of promise.
This one comes from a almost fourth year student. Do you have any thoughts on how funding of residency programs plays a role into decreased access to care? There seems to be more and more graduating med students, and the number of residency spots are not keeping up.
Yeah, that's the issue of how residency programs get funded through. And basically Medicare, kind of like that, the funding of residency programs, but how that leads to difficulty in access care. As a free market person, it's kind of hard to call for more government funding. I would love to see hospitals who are using these residents essentially as cheap labor to pull in and support training programs. And we do see things like Kaiser, which is a large HMO organization, setting up their own residency programs. I'm not sure about the nuts and bolts of how that program gets funded in terms of government funding versus private industry funding. So that's an interesting question. I do think we do have this funnel that is slowing down the training of physicians. But my answer is, we also have to look outside the physician box in terms of providing care and look at scope of practice issues as well, pulling in our colleagues, nurse practitioners, certified nurse midwives, to do some of the more straightforward medical stuff. And then we have to ask ourselves as doctors, are we practicing at the top of our license? Are we doing the difficult stuff, and letting our colleagues who are in the nursing profession do the less difficult stuff? But I can't really answer the medical education question in a very sophisticated way because I haven't looked at it in detail other than experiencing it myself. And also say that I think it's way too expensive to train a doctor. And so we're burdening our students with huge amounts of debt that then lead them to make subspecialty decisions. I love our subspecialists. I love our proceduralists, but we need a lot more generalists out there. And it's really hard to make that decision on a financial level when you know you're going to be paid less, and you basically bought the farm to get yourself trained. So I don't know if I answered that question well.
Okay, is there any option that you know of for doctors to work outside of their board certification in a field they feel comfortable with or have extensive non-residency training with?
I think if you have a hospital who will support you in that. So hospitals have review boards, and they review your cases. So, for example, in my own community, there's a surgeon who is essentially functioning as a gynecologic oncologist. He's not fellowshipped in that. He didn't do a fellowship, but he has all the cases and the training for doing the surgeries. So the hospitals looked at his training, looked at his caseload, and said, yeah, you can do that here. So it's basically on an institutional level that decision gets made.
I think we're going to dig into that, the residency question, though.
Oh, no. Let me get back to you, Al. That's a whole conversation, a whole nother.
Well, the person that asked that is the host of our podcast.
Oh, okay.
So I just told
my area of expertise by any means.
I think it's a great question, though, because that's okay. I mean, I told him we should dig into that more. So he might be asking you more. So I want to thank you for joining us today. If anybody has any more questions, contact me. My contact information is going to be at the end of this, and I will put you in touch with Dr. Bryan. I have enjoyed your work for a long time, and it put me on a new path of things to look at. I'm a constant learner and not a physician, so I know all of the things I know because of people like you. So thank you for your work. Thank you to the Mercatus Center for giving us so much wonderful information. We are an education provider, and what the information that we get, that we put out to medical students, is because of wonderful wonderful organizations like the Mercatus Center, wonderful research organizations like the Mercatus Center. So we thank you. Like I mentioned, we are talking to Matt Mitchell on the 10th of August at 1 o'clock about Certificate of Need, which has become such a huge topic, especially throughout this pandemic, because we have seen what overregulation has done and how it has slowed down so much during this pandemic. So I am really excited about that, because it's always been a big topic, but now we've seen just what has happened because of this overregulation and why we need to stop it. So that is something that we're doing on the 10th. The week after that, we are talking to something I'm pretty passionate about, is talking to other specialists outside that are doing direct care outside of primary care. So we are talking to a podiatrist, Dr. Grace, also in Florida. We're talking to her about what we're doing outside of, it's not just direct primary care that does direct pay. So we're talking to her. Just keep up to date about what we're doing, and we have a lot more coming. So thank you so much for your time. This was great, and we'll have a lot more coming. So thank you for your time.
Thank you, everyone. Thank you.